Um, First of all, thank you so much for gracing the stage and accepting my invitation to come over and talk a little bit about personalized medicine. Uh, all the physicians who are right now on the stage have been actively participating in incorporating personalized medicine in their practice. So I'm very excited to see what their perspective is, completely on the floor, like actually what's happening right now. Some of them are my seniors, some of them the same Gandhians, juniors, but I'm very excited. Uh, so today, I think our talk might be a little bit might be diagonally opposite to what the oncologist just talked about. So just bear with us. We might paint a very optimistic picture compared to what you guys just said, because we are quite enthusiastic. You guys are going, the oncology is going at the pace of a Ferrari. It's like a race car. But then we are not far behind as well. We are catching up with you guys. There are a lot of drugs already coming in, and there's a lot of active research going on. So the most important thing I want to know pretty much from everyone, I'll start off first with Dr. Dilip. You have had experience of practicing personalized medicine. You have been doing genomic analysis and using that inferences for your patients in your practice, right? By the way, he is known as the star doc. You are the celebrity doc. I would like to know what your experience is, because you are one of those progressive physicians who's incorporated it at an internal medicine level at a much earlier stage compared to some of our other friends as of yet.
Thanks, Dr. Hima and Dr. Kalyan for organizing this. Okay, so I've been using this since Dr. Hima and Kalyan have started this in 2019, but I didn't start it so early. But around 2020, I started using pharmacogenomics from Dr. Kalyan and Hima. And from my experience, I've done quite a few patients. I've done the pharmacogenomics, and few of the patients have been very helpful for them. Fundamentally, what I saw is some certain patients, there are a lot of medications which were not working. And I had to remove a lot of medications for the patients, and they have been more better after removing rather than using it. And I have changed medications for them according to the pharmacogenomics, and the control of sugars and the quality of life has improved. And over a period of time, I also learned that in India, I can't tell the numbers, how much it is, but we have a lot of people with clopidogrel resistance, which is a mostly used antiplatelet medication for a lot of patients. I have done for a couple of patients, we have been using antiplatelet clopidogrel, but these people are getting strokes, recurrent strokes. Then we did pharmacogenomics, then we came to know it's not working, changed to other things, they're much better now. So it's a small thing, it's not a big molecule also, it's a very cost effective molecule, but to find out it is not working is costly now, right now. I'm not saying it will be like this for a long time. It's like a chicken and egg situation. Unless we do pharmacogenomics in a lot of patients, we won't know what's happening in Indian population. To do that, right now we say it is costly. So unless we do that, we don't get the data. Unless we don't get the data, we can't help the patients. It may be costly for some time, but when everybody start using, their cost of doing the test will come down, and we have a lot of information, and this benefits a lot to the patient actually in terms of cost in future, cost of less complications for the future. And other thing which I understand, correct me if I'm wrong, Hima, over a period of time, as generations changing, these are all genetic modifications, we are getting cancers and all lifestyle diseases. So that means what I understand as a layman or simple physician is genes change. So if I have a patient with chronic diseases, bad diseases, cardiac diseases, strokes, and I identify their siblings or next generation people early, find out some problem is there, change the lifestyle, those genes also can change. And if we can do that over a period of next few generations, we can reduce the incidence of chronic diseases, from their complications, also cancers. So this is a very long bet to do, and it's costly to do right now. But if we start doing it, that's the thing. And Dr. Chinnababa was rightly told, digital health records. If I have a digital health record, It's not only telling about what's the disease pattern. With the risk factors, we can anticipate with the computers and AI what is the risk of disease in certain population and how to modify it. So these are the different applications we are trying to develop, and that will have a great impact in how we deal with healthcare and quality of life. It's not anymore. See, we used to 50 years back or 20 years back when I'm doing my post graduation, general medicine. We have been called as MD General Medicine. Then we came to individualized medicine. See the patient and do that. Now we are talking about personalized medicine. Next is precision medicine. Then targeted drug for specific person. That is the next stage what we are dealing with. So we are in evolution and we are evolving very fast. We have to catch up with the situation. But right now, as I know, a lot of people don't do the genetic testing for pharmacogenomics or genetics. Once we start things, we'll have a lot of knowledge and that will be helpful for the patients.
You're absolutely bang on when you talked about epigenetics. Screening not just the patient, but also if there is something, for example, say cardiomyopathy, for which there's a lot of evidence, you can actually screen the family and actually help them prevent such dangerous conditions. So that definitely is something which is adding value. Now, since you talked about pharmacogenomics, Dr. Dilip, I would move on to Dr. Vishwanath. You have been practicing pharmacogenomics. You've been looking up, part of the study as well that we are taking up at your institution, wherein, like you said, that pharmacogenomics is quite expensive. Everyone needs it. We need to know which drugs the patients respond well to. Being a critical care specialist, pulmonologist, what is your experience so far with the pharmacogenomics aspect? Because I know we've had quite a few interactions. Dr. Vishwanath is my senior in college. We used to be very scared of him because he's like very, very, very smart. Oh my God, his office reading. So I'm a little worried, asking you a question.
Thank you very much, Dr. Kalyan and Dr. Hima, for having me here today, actually. So, coming to the question, I can say that our knowledge in pharmacogenomics or in personalized medicine is early on. I've started using it for the last 1 year or so since our interaction a year ago, actually, almost a year ago. So right now, I can put it this way, actually. There are two kinds of indications, especially in pulmonary medicine, when it comes to personalized medicine. One is about the utility of this genetic testing in a particular diagnosis, actually, why a particular disease is happening. And the second is response to the treatment, actually. As you can know, sometimes patients with interstitial lung disease, I can quote a few examples, actually. In interstitial lung disease, the most common cause is smoking, idiopathic pulmonary fibrosis. However, there are 30 to 40% of the patients who have ILD who do not have any smoking history. So the question which we come across from the patients is, why did I develop interstitial lung disease? I have never smoked. Why did I develop? So probably it was better that I could have smoked. Many of my colleagues or friends who smoked did not develop this, actually. Some of them want to specifically know what is the cause for the interstitial lung disease. So in this, there are some variants like MUC5 and TOLIP gene, which are known to be associated with some familial causes of idiopathic pulmonary fibrosis. I won't go into details, but they are associated with familial pulmonary fibrosis. In these conditions, sometimes a drug called N-acetylcysteine will help, in addition to the regular antifibrotics. So similarly, in bronchiectasis also, a lot of times we see patients developing bronchiectasis because of tuberculosis, post-infective bronchiectasis, or post-viral bronchiectasis, when they have developed any viral infection in the childhood. But we also see a lot of patients who come without any previous history of viral infections, tuberculosis, developing bronchiectasis. It's very important for us to identify what is the reason for bronchiectasis in these patients. Some of these patients might be having a primary ciliary dyskinesia, which is an inheritable disease, actually. So we need to counsel the patients specifically regarding the planning of kids and everything, actually. Otherwise, because of its inheritable nature, actually, the future generations are also going to suffer with a similar problem, actually. So this comes to the diagnostic part. Coming to the therapeutic part, actually, like in asthma, we have seen that some of the patients do not respond to the regular inhaled corticosteroids. And We have not used it specifically for asthma, though it has been in discussion with you for some time that we should start using this pharmacogenomics, especially in patients with asthma who are not responding. But a review of literature, which was done actually just when I was looking through the study actually last time. So some of these glucocorticoid receptors actually do not respond to the inhaled corticosteroids. So because of some polymorphisms in the glucocorticoid receptor gene. So what we are doing now is basically we are just trying on escalating the treatment. So once it does not respond to the treatment, then we are escalating to the biologicals, which is going to be an like never-ending affair. So currently there are multiple biologicals approved like benralizumab, mepolizumab, targeted treatments like what you use in oncology. But again, never-ending process. You need to continue the treatment actually. Suppose if you're able to find this patients why they're not responding, in addition to the non-compliance of the inhalers, in addition to like triggers like anxiety or some other like persistent allergen exposure, if we have ruled out everything and if we feel that this is because of the glucocorticoid receptor polymorphisms mutations, probably I think in the near future, as you have shown about implicit that see so there might be some new molecules which might help us in overcoming the resistance to the glucocorticoid receptors. So again, in idiopathic pulmonary fibrosis also, there are a lot of mutations which are described, which are not still validated, I think, but they hold promise. So right now I can say that the field is very promising. We need to have more data, but definitely in certain conditions for diagnosis, it's helping, especially in familial pulmonary fibrosis or bronchiectasis, and understanding the responses to treatment, how we can modify the responses. So in this way, definitely it's going to help. In my experience, we have used it mainly for bronchiectasis, idiopathic pulmonary fibrosis, and we have been using the pharmacogenomics for when we are initiating azathioprine. We know that if azathioprine metabolism is actually influenced by thiopurine methyl transferase, people who have deficiency of this thiopurine methyl transferase, basically, they tend to have a lot of side effects because of myelosuppression. So we have been using this TPMT levels before starting azathioprine for our patients from very long, actually. So similarly, I have seen in the literature that for mycophenolic acid, which is a common immunomodulator drug, which we commonly use in our interstitial lung disease, there are certain mutations which again predict response to the therapy. So I think probably we are underutilizing it. So definitely we need to have a cautious optimism and then probably study a subset of patients who are not responding and see why they are not responding, whether it's because of some mutations. That's what I can say about that.
In terms of pulmonology, I think we've just scratched the surface. There's a lot more that needs to be done. There's just a few conditions that we have been able to see the pharmacogenomics effect as of now. I think needs to be more studies, and like you said, more patients need to be enrolled, and we can't really give that cost to the patient because that's going to be very expensive. Let's dive into another topic. The problem with personalized medicine and internal medicine is the conditions that we treat, most of them are called the common complex disorders. All of them, any condition will have at least 100 gene variants which might be responsible for causing the disease. So to look at whether a person is predisposed to a certain condition or not, or what drugs work for him, it's not such an easy task. And even for the physician to incorporate it, it's quite difficult. I have Dr. Nitin, who I have interacted with him quite a lot of times. He's an endocrinologist. He's using it for a lot of his patients for diabetes. I just want to know, how is it going? How are they following up? And what your experience is with personalized medicine so far.
Thanks, Himaji, for making me part of this wonderful program. So usually what happens in diabetes is, as we all know, diabetes is on rise, and we witness more and more of young onset diabetes in the last 1 decade. So India is the capital for diabetes. So here we need to make sure that India is on top when it comes to the new advances that come with the diabetes management. Of course, there is some original work that is being done from Dr. Mohan's Institute and this segment up, because they made sure that they have recognized phenotypes of diabetes. Is it insulin resistant, insulin deficient, or a combination of both of these to begin with? So that makes our job easy. That's a point. That's where the precision regarding the medicine, because we have around 4 or 5 agents when it comes to diabetes in managing, and we have insulin as well. But which among all these agents is the right agent to that specific individual? So there lies the importance of genetic testing as well. I know this is an evolving phase, and more and more data will keep on accumulating, and we will subsequently the data will also be there available for the guidelines as well. But as of now, there is no mention about the usage of pharmacogenomics in the guidelines. But at our institute, we have been enrolling patients since past 1 year as part of this specific study, and we are in the midway, and as part of the next step, we are going to collect the data and then look at the phenotypic changes, and we are at a stage where we are planning to make the necessary treatment changes to that individual, and then follow them up down the line, and then see for the improvement happening in these individuals. And as said by my colleague doctors as well, lot of scope in this segment, because any person, especially the place where I practice, very well educated person, of course, incidentally diagnosed with diabetes, they wanted to know what's the reason for diabetes. Some people may ask, may say, my parents don't have diabetes, why me? So we need to have an answer to many of these questions with respect to diabetes. And some people will ask us, will I have diabetes down the line? If so, when and what should I do to prevent? No answer. Time will tell. So unmet need, and I think pharmacogenomics as well as genetics will be of great help in this specific segment, where diabetes is there at each and every household these days.
Absolutely. Like you said, pharmacogenomics is still evolving for diabetes and all of the internal medicine specialty conditions. But still, the data is definitely out there, and we can start incorporating and see how patients are responding. For diabetes specifically, I think for screening protocols also, we can probably use it, because if they're more prone to nephropathies or the microvascular complications and all, right? So yeah, definitely, I think the future is quite bright for that. Now, last but not the least, the beautiful and talented Dr. Samata, who just does not stop. She's constantly improving her knowledge on personalized medicine. She's a pro in personalized medicine. I kept you at last year. I have a lot to learn from you when it comes to personalized medicine, though you are my junior. She does it not just, you just don't do it for the pharmacogenomics part like most of us do. You are incorporating it at the entire, like the 360-degree patient, profiling, everything you're looking at, from screening, diet, and everything. And you incorporate some other modalities as well. I want to know what your experience is. How's it going? How are the patients responding? Is it okay? Is it bad? Just tell me it's okay, okay?
Thank you, Hima. I'm humbled with your words. So I'll slowly start moving away from the spectrum of oncology, diagnosis, pharmacogenomics towards predictive medicine. There is no use of decoded genomics without proper actionable evidence. That is where predictive medicine comes into play. The clients walking into my clinic are either with metabolic disorders. Most of them are metabolic syndromes, obesity, diabetes, hypertension, and most of them are middle-aged women and men. And most of them are in pre-diabetes or post-pandemic syndromes, where they're sitting idle, sedentary, non-exercise most of the time, landed with high LDL and all those things. So as part of my screening, there are multiple omics that comes into play when it comes to precision medicine. Top one is genomics. Second is looking for biomarkers of metabolism. What is happening with vitamins? Most of the doctors here do write serum D3 levels, serum B12 levels, not to offend anyone, but serum B12 levels, does it actually give the value of B12? No. How about the intracellular B12 levels? So that is where this test comes into play, which is called markers of metabolism. It could be vitamins, minerals, lipids, carbs, fats, and also none of us before also, I didn't have this knowledge of testing for CoQ10, alpha lipoic acid. Now we do have tests available. Of course, Hyderabad do not have these tests. I send them to Bangalore or Bombay to get these tests done. How are these helpful? Many of the patients have very non-specific symptoms. I think physicians have got a major task. Where do I put this patient in? Where is the diagnosis? This patient do not have a diagnosis. That is the most common problem we physicians do have. It's not necessary that we have to put them into a diagnosis. What is happening? Is it the metabolism with carbs, or is it the problem with the nutrients, or is it the problem with the hormones, or is it the problem with detoxification? Where is the patient falling? We have to cover all these aspects and put them into a treatment plan. So when it comes to prescription, it has changed over the years for me from the past 3-4 years. First, I used to prescribe medicines. When I freshly passed out of MD internal medicine, started prescribing medicines. Now my first prescription is a diet plan or a nutritional plan. That is the way going forward. As all physicians should learn to modify their diet first. That is where the biggest answer comes, and that is where the treatment starts changing. So when it comes to comprehensive genome analysis that I get it done from you, what I look into is the nutrigenomics. How can I affect nutrition plan using your genetics? That is what is the answer. Surprisingly, out of few patients that I tested, 60 to 70% of them had this ApoE2 gene variant where they're not suitable for keto diets or high-fat diets. Here is the blast. So I called up Hima and I asked, Hima, I want the data. Most of my patients are showing they're having ApoE2 variant. Please check and let me know what is the data happening in India, because I see most of them are doing keto diets. It could be for metabolic syndrome, diabetes, hypertension, everything. Yes, keto diets work very well because we are going off insulin, we are keeping shutting down insulin, and there are tremendous results. Also, there are certain side effects which are happening because most of them are going through apps, going through some nutritional apps that are going on. Hima actually told me about 60 to 70% of the South Indians do have this variant. Now I was very cautious. I now seriously look into what nutrition I actually put them into. And this is one aspect. Second most important aspect is the sudden cardiac deaths or sudden deaths that are happening in the country right now. So I look into fitness genomics, which is also a part of comprehensive genomics or gene power total that you do for me. So in that, we often see fructose 1,6 dehydrogenase deficiency, butyryl methyl dehydrogenase deficiency. All these put them at risk for sudden cardiac deaths when they go on high intensity workouts. And they are dehydrated and have gone to a workout, or they have not slept and have gone for a workout. Actually, research shows high intensity interval workouts are very good for all these metabolic syndromes or diabetes. Now, when genes variants like this are showing, I can't put them on high intensity. Next day is going to die and family is going to sue me. So this has been very helpful for me. The fitness genomics, nutrigenomics, of course, pharmacogenomics is always there when I'm going to treat certain individual for the disease process. So predictive medicine is going to be the future, is what I feel in coming next 2 to 3 years. It is not very far away. I'm sure there are very young doctors budding in from this room right here going to incorporate this predictive medicine. And when we talk about predictive disease processes, the disease risk, what we also do part of the comprehensive testing. Yes, we look at, you give the risk score, right? Severe risk depending on the variance that is there. And we have to incorporate epigenetics. So their age, other risk factors, their lifestyle and everything. So you're able to give me an appropriate assessment score is what I feel. My assessment score without genomics is falling short. But this genetic risk assessment score is adding up. So the particular patient who was at low risk according to the lifestyle may be at a higher risk according to the genetics. But again, loaded gun needs to be triggered if you want to shoot them, right? So not every person who is having genetic variant for that particular disease is going to develop a disease. Please, they're not going to. We should outsmart our genes. Though we have, I'm sure you have a cousin who has many genes positive for breast cancer. She is doing so well. Why? Because she's outsmarting her genes with exercise, nutrition, and keeping the disease away. So though prediction of disease risk is there through genetics, we can always change around with epigenetics. And I think that is the key factor. Thank you.
Bang on, Samta, bang on. Actually, that's absolutely right for internal medicine specifically. I think not just the pharmacogenomics and screening protocols. This gives us the edge for making sure that we are putting patients on evidence-based diets. We're telling them eat according to your genes, which what will help them. And yeah, like you said, it's quite surprising. A lot of our Indian population, we are not really fit for those kind of heavy, high intensity workouts which are happening these days. People just copy the West. Oh, he's doing, we'll also do it. Our muscle mass is different, creatinine, everything is different. So we have to look at this picture as well. And this gives us physicians a tool to actually tell them with evidence that this is what is happening. And I'm glad that you are actually using it and seeing the response too. So I think internal medicine specifically, personalized medicine is like an all-round tool where we can use it for the diet and lifestyle as well, the epigenetics part. I think, yeah.
I just wanted to share my personal experience. I've got my genetic testing actually. So there was one variant which said that I should not do an intense workout and I should go for a moderate exercise. Whenever I used to go for an intense exercise, I used to become fatigued immediately actually. But after that advice, I shifted to moderate kind of exercise. I used to see a lot of my friends here like Vamsi and all who used to go for 5K runs, 10K runs, then a lot of other friends as well, right? So then I told myself that, see, I think for my body, probably that intense kind of exercise is not what is suitable. And then I've shifted to a moderate kind of exercise actually. So I think this is something very promising, nutrigenomics and then workout genomics. I think that's very, very interesting. And also I think a lot of people will benefit from that actually.
Is it working now? That's working. So I think the terms we are using, fitness genomics, nutrigenomics, is just for the patients to understand. But bottom line, they are just metabolism variants that we are looking at. And they all have a physiology process behind them. So if we look at that, I think that will be very useful for the patients. I think we are ready for some closing comments.
Sure.
Dr. Dilip.
Hello.
1 second.
Yep. Sure.
Yeah, as Dr. Vishwanath told, I too did my pharmacogenomic, total genomic. So similar thing has happened. My diet and exercise schedule has changed. But as you told, I stopped high intensity and not doing any exercise now. Because it showed you don't do any high intensity exercise. Okay. So that is one risk to that. And what I say is, from my perspective, I'm seeing patient from last 15, 20 years. Don't assess the patient that he can afford or not afford the test or medication. Just suggest to them. We'll be surprised to know that how many people will want to do it. Okay. Seeing the attire or the way they're talking or how they come, please don't judge them. Give the option. Let them decide. And you'll be very surprised to see that you will never believe that this person will be doing that. That person will be doing all the tests and will be following you well also. So just give an option. What is the best option available and what you know. And let the patient decide. We don't decide for the patient. They can afford or not afford this pharmacogenomics or nutrigenomics or diet genomics, whatever it is. Just give an option. Then we'll see the response, how you get it.
That option to the patient. Very, very rightly said, Dr. Dilip. Any of the other closing comments, Dr. Nitin? Anything? Nothing?
So, say, whatever you covered, like nutrigenomics or pharmacogenomics, everything, so that can be covered as a part of whole exome sequencing, right? Which comes in around 25,000?
Factor anymore for that.
We often don't realize the cost of the medicine which we are using. Once I happened to ask my patient about the cost of PPIs which they're using. Each PPI, esomeprazole or someprazole which they use would be around 20 to 25 rupees actually per day. So when a long run, if you calculate the cost, I think the cost of medications which we use is going to be a lot more than what we actually offer as a part of the genetic testing and the triaging actually. And if further the cost comes down, I think the usage will increase, as you say.
You don't have to repeat this for your patients multiple times. It's just a one-time thing because the changes that will happen, like you said, it's going to take generation. So once you do it, it's done for the patient. So you should definitely offer that. Any questions, guys?
One commonly asked question to me, which I'll address today. Don't your patients get anxious when you get a complete genome sequencing? Is what they ask. Are they not afraid to get their disease prediction? So this is not my perspective. This is a research article published in the Journal of Clinical Genomics. It says that people who get their genetic screening done, their adherence to treatment is far better than people who are not screened. So that notion of becoming anxious is no more there. And second question, which I would like to address is regarding doctors. Will your treatment change after you get genetic screening done for your patient? This is again published in New England Journal. 70% of the time, physician is going to change the screening protocol, like follow-ups, or even change the treatment protocol after getting the genetic screening done. So these are the most commonly asked questions to me. Yes, so it's very promising. So I think we should all start using genetic screening for our patients.
Hi, my question is for Dr. Samantha. So you're talking about predictive medicine, right? So it's similar to like preventive health. So
Yes.
there are a lot of cases, if you can detect in a very early stage, right, using these metabolic biomarkers, do you think we can prevent a lot of diseases? Like you're speaking about biomarkers for several diseases, like vitamins, or you're looking into EPA or DHA levels. Do you think predictive medicine can be very helpful in the future, or like because the cost of testing after getting a disease is very expensive. If we can do it at a very early stage and predict these biomarkers, do you think that will make a difference?
Thank you for your question. So again, I would like to cite some examples here. There's a Jupiter trial which was done, which indicates that people who got the genetic testing who had very high risk for coronary artery disease, but currently the LDL levels are normal, but their inflammatory markers like CRP are high. If these individuals are put on statins, their risk of myocardial infarction falls by 44% and risk for strokes fall by 50%. So this is the power of preventive medicine or predictive medicine, where more data is coming in, and we can moderate the drugs, nutrition around that, so that we can decrease the healthcare costs as well.
But Dr. Samantha, do you think the patient will panic, like when you're really detecting at a very early stage, like these biomarkers? We are doing HSCRP, like even before getting diabetes, the HSCRP levels are very high. So, but once we tell it to them, right, do you think the patient will panic? Is it like, how do you deal with such cases, or
Yes, we deal with that on day-to-day basis, but you don't reveal the answer just like that. You have to take their history. In the history, the people are already guilty that they're either sedentary, not doing exercise. Half of the story is already heard. So I don't think they'll be more surprised to hear that their biomarkers are high. So they're giving you half of the answer. So I don't think it's the stage of panic, it's the stage of awareness and what you're going to do around it, and what preventive measures can you provide as a doctor at that stage and prevent the disease many years before.
Thank you. Thank you.
Thank you.